So what is the second stenosis? This is the normal pulmonary artery cross section. It has become structural change resulting in reduced stenotic, that is a vascular area becoming stenotic. Prognosis is poor, that is which people don't survive more than 2 years. Pulmonary vascular resistance more than 3 Wood units, or pulmonary artery systolic pressure more than 80 millimeters of mercury. At the end of 1 year, only 50% survive. What happens in the RV? This is same. Once they develop pulmonary artery hypertension, the RV undergoes remodeling similar to the LA, resulting in RV hypertrophy, initially compensating with the increased contractility. Later, as the balance of the Frank-Starling mechanism gets imbalanced, they develop right ventricular dysfunction by echo followed by right heart failure. So, right heart failure feature predominate, not the mitral stenosis picture. What is the basic pathophysiological hemodynamic burden causing all the symptoms of mitral stenosis? That is the increased pulmonary venous pressure, increased pulmonary artery pressure and right heart failure. Forward output also reduces. Why the cardiac output reduces? There are almost 7 causes. Left ventricular, right ventricular, interventricular septal causes and vascular causes. Right ventricular causes we saw earlier because of increased PAH. Right ventricle fails, the right ventricular output reduces. Same RV is the LV output. So, LV output also in series reduces. What is the LV cause? Because of the reduced mitral valve area, LV is underfilled. So, underfilled LV contracts lesser, resulting in reduced cardiac output. And similar to the valve, you can see the valve, the left atrium and the left ventricle. The subvalve also undergoes fibrosis, not in isolation but along with the endocardial border. The LV also undergoes fibrosis. This effect can be very well seen after opening the mitral valve. Once the balloon mitral valvotomy is done, normally the LV function should be normal or hyperkinetic LV, but this phenomena is not seen. The LV function drops further. The moment you give the extra blood, this is not able to compensate, resulting in LV dysfunction following a delayed mitral valvotomy of a severe mitral stenotic valve. So, there is scarring of the endomyocardium along with the subvalve apparatus. Abnormal IVS movement because of the either dominant RV or under dominant LV, resulting in reduced cardiac output, which is not able to adapt initially after the balloon valvotomy. Presence of atrial fibrillation, chronic atrial fibrillation or permanent atrial fibrillation resulting in tachycardia related cardiomyopathy, and embolism to the coronary arteries or associated atherosclerotic disease, or peripheral vasoconstriction resulting in increased afterload reduces the cardiac output. So, all these parameters of reduced cardiac output, systolic dysfunction, they all reverse rapidly with the opening of the valve, either with balloon mitral valvotomy or after MVR. There is drop in the diastolic function also because of the LV remodeling, stiffer LV endomyocardium because of the fibrosis along with the subvalve apparatus, resulting in diastolic or filling problems, and regional tethering with along with the subvalve apparatus and distortion of the subvalve apparatus resulting in diastolic dysfunction. How you stage? Staging is dependent on the structure of the mitral valve as seen by the echo. There are 4 stages according to American Heart Association, American College of Cardiology. A, B, C and D, like any other valvular disease. A is at risk, B is progressive, C is severe asymptomatic, D is severe symptomatic. So, the level of intervention is the C, level of C, and A and B are for follow-up. So, what is A? At risk for MS, the mitral valve is affected, that is seen by doming movement of the anterior mitral leaflet during diastole, but the flow velocity is normal, that is no increased pressure across the mitral valve, or LA pressure is normal, they are asymptomatic and there are no hemodynamic consequences. They are for follow-up every 3rd to 4th year by echo. B, stage B is the progressive MS, that is anywhere starting from stage A before they reach the severe stage. What is severe MS? Less than 1.5 square centimeter valve area. So, anything more than 1.5 square centimeter measured valve area by planimeter, but has Rheumatic valve changes like fusion of the commissure, thickening of the valve or subvalve, or calcification and reduced mobility by echo, increased transmitral flow velocity and valve area more than 1.5. Diastolic pressure half time, what is that? We will see in the coming echo pictures. Anything less than 150 millisecond. So, they can have mild hemodynamic consequences, not major, that is there is no pulmonary hypertension, no AFib, no symptoms of increased PVH. Class stage C is a severe MS defined by planimeted mitral valve area less than 1.5 or a gradient between the LA and LV more than 10 millimeters of mercury, but they are asymptomatic. There are hemodynamic consequences of increased gradient, reduced valve area, but no PAH, no significant PVH. PAH may be more than 50, but they are asymptomatic. While class D is, stage D is a symptomatic and severe mitral stenosis, same as echo pictures, but they have significantly enlarged LA, PVH, PAH, reduced effort tolerance and exertional breathlessness.